I want to thank all the speakers because they really prepared all the slides and they have perfect timing. And now we have a brief summary, and I'm sure that we still have time for questions. First of all, Dr. Catoyo presented what I will call the past, the present, and the future of GLADEL. He was really proud about presenting our data. And I say our data because it's data generated by Latin American centers. And now we don't have to present data from other countries, from other regions, from other ethnic groups. We have our own very important data. Thank you for that, Dr. Catoyo. Dr. Van Vollenhoven introduced a concept that rheumatologists are very familiar with that, the concept tree to target. It's very interesting. He described that this is a work in progress, but I'm sure that clinicians will be eager to see how remission or low disease activity will be defined for lupus patients. He also described that we have to go beyond disease activity. We have to look at other outcome measures in our patients. That's a very interesting and challenging point. Dr. Fury, as usual, described the main challenges in developing new biologic treatments for lupus. He described how this step has produced some medications that will be very useful for our patients. He also said that now we are living in a different era that will present a very optimistic way to describe and to study other potential medications for these patients. And finally, Dr. Collins presented something that clinicians want to hear. Sometimes the stiffness, the rigidity, the methodology of clinical trials, we think that that cannot be applied to clinical practice. Researchers working with lupus patients, lupus trials, are very frustrated because most of their patients cannot be included in the trial. Dr. Massardo presented one of those cases. And at the end, we have an approved medication that we want to use, but our patients are quite different of those that were studied in the clinical trial. So this kind of information is very useful for all of us, particularly with a new drug that we want to see how it behaves in the real world. And very interesting information was presented. I was particularly impressed by the steroid-sparing effect of this medication in any of the ethnic groups studied in 6 months in an open-label study in the United States. And I don't want to take more of your time. I want to open this for questions and discussions. There are several microphones, and I want you to identify yourself and please direct the question to the speakers. Please, first question.
Gracias. Maybe you can wear this.
Questions in English.
If you want to make the question in English, if you feel comfortable with that, that's great. If not, we have translators.
Well,
whatever you want.
This is a multilingual Congress, isn't it?
Whatever you want, that's great.
Okay. So, la primera pregunta que le quiero hacer a Ron, digo Ron porque su apellido es más difícil que Hübscher, me pareció ver que en la larga lista de miembros del comité del T2T en SLE no había ningún latinoamericano. Es una pregunta que hago. A lo mejor, ruego me disculpen, pero a lo mejor no tuve tiempo y no detecté ninguno. Esa pregunta número uno. Pregunta número dos es la siguiente. Una de las preguntas que los médicos que vemos pacientes con lupus nos hacemos con toda frecuencia es ¿cuál es el paciente ideal para recibir, para que se le indique belimumab? En esta semana salió a mi juicio, muy buen review de belimumab en lupus by Bebrahan en el New England Journal of Medicine, This Week, y ahí el review comienza con la descripción de un caso clínico de un paciente que recibió belimumab porque no respondía al tratamiento estándar. El paciente no tiene anticuerpos anti-DNA, no tiene hipocomplementemia y tiene un título muy bajo de ANA. Entonces, a lo largo del review se dice que la indicación más plausible para belimumab son los pacientes que no responden al tratamiento estándar, como fue explicado acá por el último orador. Ahora, la pregunta es, como el trial exitoso de belimumab está basado en la seropositividad, la pregunta es, los pacientes que no responden al tratamiento estándar para ser candidatos a belimumab, ¿tienen que ser también serológicamente activos? Porque esa es la esencia del trial exitoso con la droga.
Yes, thank you very much. So, first of all, the Treat to Target and Lupus initiative was initiated in Europe, but Roger Levy was also participating in the discussions and in the ongoing work as the sole representative of Latin America. And we recognize that this is not completely represented in all facets worldwide. But to your second question, of course, very critical for us to understand as clinicians how we're going to use belimumab and how to find the right patient for this. And I totally agree with you that seropositivity was really, first of all, a criterion for the trial, so the patient had to have ANA or anti-DNA, but also in the subsequent analysis, it was clearly shown that if you had anti-DNA, and especially if you also had hypocomplementemia, which of course often goes hand in hand, you had an even better likelihood of responding. So when we have chosen this treatment, it was indeed for patients with persistent disease activity, no success with conventional therapies, corticosteroid need, which is often a long-term concern, and then the serology. The case in the New England Journal of Medicine did not have all those features. The patient discontinued the treatment already after 4 months, which was maybe a little bit too early to be sure. Maybe she could have responded later on. I think the author, Professor Bevra Hahn from UCLA, indicated also in her comment that she felt a longer trial might have been warranted, but that was just in that one particular case.
En el comentario final, en este review se indica que en the US los third party payers no aprueban, suelen no aprobar belimumab en pacientes seronegativos.
¿Hay más preguntas?
I do not know.
En medio, por favor. In the middle.
It's very variable as far as the requirements to prescribe Benlysta. So certainly in my area in New York, none of the insurers are requesting SLE dyes or to look at laboratory values.
Dr. Scheinberg?
Yes, so we're going to go in English. Dr. Collins, even though it's a short period of time, 2 years, what is the possible statistics we have that patients started on belimumab stop it for a combined reason, lack of coverage, lack of response, side effects? Do we have any hint with what this kind of number could be?
Would you repeat the last part of that question? It's a little muddled.
The question is, in this 2-year period that belimumab is approved, what is the percentage of patients that we have to stop belimumab for whatever reason, lack of coverage, side effect, and adverse event, and lack of efficacy?
So your question is what percentage of patients have had to stop belimumab since it's come to market in the United States? And I don't have that data. I know that the marketing team has suggested that about 18% of so patients have come off of the medication after it has been initiated. I think the mean time was around 3 to 4 months, and there's still some questions as to why that was removed, and we're trying to get a little bit more data to ascertain those patients that do come off, why is it that they're coming off, and is it because of perceived treatment failures? Is it because of intolerability? And unfortunately, our initiative, that was not something we looked at specifically. We only looked at those patients whom had gotten to a 6-month and then assessed overall clinical efficacy at that time. So obviously there's a little bit of bias to overall patients getting to that point likely to have done well, but it is a worthy question to ask. How many patients are coming off, and really what is the reason for it?
We have 2 more questions.
Yes.
Yes. In this study, what was the number of patients needed to treat to achieve SRI response criteria? Do you have that data?
Which study, Dr. Collins, the open label or the BLISS?
Both of them, if you have the data.
So then you're asking about the number to treat? So with an effect size of 10% to 15%, just divide that by 100. So we're talking about 1 in 10 or less, a little bit less.
My name is Francisco Fons. I work in an autoimmune disease unit in Portugal. And I'd like to go back to the beginning of the session, to Dr. Van Hoven's presentation. So he presented a very beautiful slide in the treat-to-target approach. And at the center of the slide, there was the word cure, which he said would be probably quite impossible in the near future. And I'd like to challenge that. And this may be a bit inappropriate, and I don't want to be misunderstood because this is not a scientific statement or question. But I really feel that all of these clinical trials, which are so expensive and take up so much of valuable, intelligent physicians' time, should really be accompanied by more research at a fundamental level. And in Portugal, for instance, I know we have a crisis, but probably it's not very different from the rest of Europe. It's very difficult to get grants and funding for basic research. And I think this is true. Not just for genetic studies or for whatever type of approach you want, but this is not easy. And I feel that maybe pharmaceutical companies have a responsibility to accompany these very targeted approaches with some fundamental questions. I'd like your comment on that.
I think I understand your point very well. And of course, when I said that cure was not possible right now, that is, I think, true. But also, I am sharing your optimism that we will start talking about cure in the not too far future. And it will start, I think, with the patients who have been diagnosed recently, where the disease is early, where maybe in a few years' time we can start thinking about trials where we treat very aggressively to try to achieve that. But it will take a longer time before we can offer any hope for cure for patients with established disease. In the meantime, we also, of course, have to continue with the treatment for those patients. So it's both true. Thank you.
If there is no more questions, I would like to thank all the speakers and thank you all for coming. And I believe the message and is left. We have to work more, but we have better medications right now. Thank you.